All right, good morning, team. Let's jump right into this explainer. I want you to imagine we're just starting morning rounds. Our goal today? Mastering a really high-yield, purely practical framework for evaluating and managing acute coronary syndromes. We're taking this straight from the textbook directly to the patient's bedside. I'll be your attending today, and we're going to cover the whole shebang, from that crucial initial patient handoff all the way to writing up a safe, absolutely bulletproof discharge plan. Let's get started.
First things first, look closely at this quote. Time is muscle. I literally cannot stress this enough. Once that artery closes, ischemia turns into irreversible necrosis in just minutes. Before we even glance at an ECG or draw a single lab, you've got to understand the life-or-death stakes we're dealing with here. Every single minute of delay in our thinking or our workflow translates directly to dead myocardium.
So here's our agenda for the shift. 1. Anatomy of an ischemic event. 2. Bedside clues and mimics. 3. The two-question mental model. 4. Mapping leads to culprit arteries. 5. Medical management and risk scores. And finally, 6. Reperfusion and discharge. Okay, let's dive into this. Section 1. Anatomy of an ischemic event. Before we can treat the patient, we really have to understand the mechanical breakdown that's happening inside their chest. Check out this precise progression. We start with a perfectly normal artery over on the left, but over time, a vulnerable plaque forms. The kind characterized by a thin cap. The defining emergency happens the exact moment that thin-capped plaque ruptures. Instantly, platelets pile on and a growing thrombus forms. It acts like a physical dam that just chokes off blood flow. This mechanical disruption, that's the shared trigger for the entire spectrum of acute coronary syndromes. So the absolutely crucial point is right here. How much of that vessel is actually blocked? The difference between unstable angina, NSTEMI, and STEMI relies entirely on whether the occlusion is subtotal or total, and whether actual muscle cell death, necrosis, has occurred. Notice how both unstable angina and NSTEMI involve a subtotal occlusion, right? But only in an NSTEMI do we see positive troponins, which tells us cells are dying. In a STEMI, it's a total occlusion. Full stop.
Moving on to Section 2, Bedside Clues and Common Mimics. Let's shift our setting directly to the patient's bedside. When you're presenting a new admission to me on rounds, I expect you to look past the obvious and catch the subtle clues.
A solid classic handoff will describe crescendo pressure radiating to the jaw or left arm, often with those familiar tagalongs like diaphoresis or nausea. But be warned, team, nearly a third of all heart attacks present without any chest pain at all. Atypical presentations, like just simple fatigue or indigestion, are incredibly common, especially in high-risk populations like women, the elderly, and diabetics. Seriously, if you have an elderly diabetic patient presenting with sudden profound fatigue, ACS must be high on your differential. That is a common pitfall you do not want to fall into.
I want you to burn this phrase into your memory. A normal physical exam never clears ACS. Don't let a quiet chest give you a false sense of security. You must actively hunt for the physical signs of ischemia and failure. Listen closely for an S3 or S4 heart sound, or a brand new mitral murmur, which could mean papillary muscle dysfunction. And check for vascular clues. Always look for asymmetric blood pressures and listen for carotid or femoral bruits.
Now let's use a little Socratic method. You're at the bedside, the patient has chest pain. But what if we anchor on atherosclerosis and we're just dead wrong? What else must you ask yourself during that high-stakes handoff?
You have to rapidly rule out the mimics. Is it type 2 ischemia? Remember, that's a supply-demand mismatch often driven by tachycardia or hypotension, which we see all the time in our older or chronic kidney disease patients. Could it be stress cardiomyopathy, also known as Takotsubo? What about myocarditis, a direct cardiac contusion, or, worst-case scenario, a deadly aortic dissection? Always keep these secondary causes in the back of your mind before you blindly commit to a plaque rupture pathway.
All right, Section 3, the two-question mental model. To cut through the noise of a chaotic emergency room, I'm going to teach you the most crucial conceptual tool of this explainer. It's a really simple, stress-reducing mental model for rapid patient sorting.
Whenever you're faced with a potential ACS case, just ask two binary questions. 1, is the troponin up? 2, is there ST elevation? That's literally it. If it's no to both, you're likely looking at unstable angina. If the troponin is elevated but there's no ST elevation, you've got an NSTEMI. If there is ST elevation, you have a STEMI. Let's look at a quick case comparison. Patient A has no ST elevation but rising serial troponins. That's your NSTEMI. Patient B has massive ST elevation on the monitor. That's your STEMI. The ECG and troponin do the sorting. Everything else just builds on them.
And this brilliantly illustrates the ECG correlates. On the top and middle strips here, we see ST depression and T-wave inversion. These correlate directly with a subtotal occlusion, so ischemia without total blockage. But look at the bottom strip. See how the ST segment is lifted up? That ST elevation signifies a total occlusion.
Section 4, Mapping Leads to Culprit Arteries. Let's move on to the next phase of our diagnostic morning rounds. We need to translate those abstract ECG squiggles into literal cardiac anatomy. We need to find the specific culprit vessel.
Here's an excellent visual mnemonic for mapping the anatomy. The pattern of leads points directly to the culprit artery. Blue is septal and anterior, tracking to the left anterior descending artery. Green is lateral, mapping to the left circumflex. And red is inferior, mapping mostly to the right coronary artery. You should start your reperfusion thinking right here, based on this color map.
As a resident, consider this table mandatory memorization. Notice how the anterior leads V1 through V4 map to the LAD. Leads 2, 3, and AVF point to the inferior wall, which is usually the RCA. But pay very close attention to this massive trap. In an inferior MI, always grab right-sided leads like V4R to catch a right ventricular infarct. If you miss an RV infarct and give nitrates, you will absolutely tank their blood pressure.
Let's keep moving. Section 5, Medical Management and Risk Scores. Transitioning to the immediate treatment phase. You've made the diagnosis. Now what? What are your non-negotiable first steps?
You have to act fast. Number 1, get that ECG within 10 minutes of arrival. You're looking for ST shifts or new left bundle branch block. Number 2, draw serial troponins on arrival and again at 1 to 2 hours. We're tracking the rise and fall here, not just relying on a single static number. Number 3, administer chewed aspirin, 162 to 325 milligrams, immediately. Chewing it means it absorbs faster, instantly lowering the risk of death and reinfarction.
Now, let's look at how we build our clinical decision-making using risk scores like HEART and TIMI. Think of this as your template for summarizing the clinical picture in the patient's chart and your checklist for documenting your rationale for discharging or admitting. If a patient is high risk, say they've got significant ST deviation, known CAD, and elevated troponins, they need an early invasive workup and admission. But if they have sharp pleuritic pain, a normal ECG, normal troponins, and score low risk, you can use a CT coronary angiogram or a stress test to safely rule out disease before a definitive discharge.
But what if it's a specific tricky scenario, like Prinz-Metal variant angina or a cocaine-induced spasm? In younger patients, smokers, or those with recent cocaine use, the mechanism isn't a fixed plaque, it's a transient coronary spasm. Your first-line treatments here are calcium channel blockers and nitrates. And listen to this critical warning. Do not use non-selective beta blockers in these patients. It can leave alpha receptors unopposed and actually worsen the vasospasm.
Okay, final stretch. Section 6, Reperfusion, Complications, and Discharge. We're moving into the final phase here, the race to the cath lab, dealing with the terrifying fallout of a massive MI, and finally, signing the patient out.
I want to aggressively drill these time-is-muscle clocks into your head. If you're at a capable hospital, your goal is a primary PCI within 90 minutes of first medical contact. If you need to transfer them, your absolute maximum window is 120 minutes. If PCI is completely out of reach, you must administer fibrinolytics within 30 minutes. Never, ever let the debate over the method delay the time to reperfusion. Just open the artery. Now, if we're debriefing after a code or a rapid patient decline, these are the complications we're analyzing. Did they go into cardiogenic shock? We need to revascularize and use axial flow support to keep the cardiac index above 2.2. For arrhythmias, treat VT and VF per ACLS, but remember that accelerated idioventricular rhythm, or AIVR, is actually a benign sign of reperfusion, so just leave it alone. And watch out for deadly mechanical catastrophes days later, like a free wall or septal rupture. These usually present with a sudden, new, harsh murmur. We finish rounds with the definitive discharge checklist. Every ACS patient leaves with daily 81 mg aspirin, a P2Y12 inhibitor like ticagrelor or prasugrel for about 12 months, and a high-intensity statin to aggressively drive their LDL below 55. Add a beta blocker and an ACE inhibitor, especially if their ejection fraction is reduced. But as you sign this chart, I leave you with this final thought. Opening the artery in the cath lab fixes today's emergency, for sure. But looking at this medical and lifestyle checklist, are we merely reacting to the last plaque, or are we actually doing what it takes to stop the next one from bursting? Think about that for your next shift. Thanks for joining me on Rounds.